Hello again, how are you? Now we're going to start the IHS or seminar number 6, and that it's about antepartum hemorrhage. This chapter, this seminar, it's a continuation of the seminar number 4. So it's very important for you to, before looking this class, you have to look the class number 4. In the class number 4, we talked about we talk about the general approach of a patient that is bleeding during the pregnancy, approach with 5 different questions. And after that, we talk a little about the different causes and the treatment of the bleeding before the 28 weeks. And now in this class, we're going to continue talking about this, but now in the bleedings that occur after 28 weeks, from 28 weeks until the delivery. And that bleeding, we call it antepartum hemorrhage. So we will see a lot of different things about that. So the things that we will check in this class, in the objectives of the class, is we're going to make a review of how to approach bleeding in pregnancy with the 5 questions. Then the definition of antepartum hemorrhage. Also, we're going to talk about all the different causes that we have of antepartum hemorrhage, and we will teach you a mnemotechnic word that can help you to remember all the causes and never forget one. So we're going to classify and have the specific causes of each type of bleeding, and how to perform the initial study and the treatment. And finally, we're going to talk a little about the triage of these patients, like how do we select the severe patients, when we have to call the consultant, when we can discharge the patient by ourselves, etc. So first, to start, as I suppose that you have seen the seminar number 4, which are the 5 questions that we should ask ourselves when a woman is bleeding? I need you to pause the video and think a little about it, maybe write them down in a paper. Because this you need to have in your mind. You cannot start looking your books when the patient is coming. You need to have like a little idea of which are the things that you need to ask yourself, or at least you have to know the first one, that is the most important. And after that, I'm going to show you. So these are the 5 important questions that you need to ask when you are in front of a patient, a pregnant woman that is bleeding. First, to know if the patient is stable or not, to check the perfusion, the ABC, the BP, if the patient is neurologically stable or not, all of that. If the patient is bleeding a lot profusely, it can be that she's not stable. Also, where is the bleeding coming from? You need to know where is the bleeding coming from. Maybe a PV bleeding, a vaginal bleeding, doesn't mean that the bleeding is coming from the uterus. You need to check it. After that, check if the patient is really pregnant or not. In this situation, in APH, the patient now is more than 28 weeks, so it's very obvious. You can see the uterus and everything. But here, you need to check if there is something inside the uterus that is alive. So you need to check if there is fetal heart rate, because that shows you that the patient have a viable pregnancy, fetal heart rate. Okay, and you can confirm that with a scan. For how many weeks of pregnancy the mother has, also is useful the scan here, and the gestation by date and by physical exam, because to know how many weeks you can classify between APH or early pregnancy bleeding, and also because the treatment is very different between ages, because you have to put in a balance the risk for preterm for the baby and the risk for the mother that she's having because of the bleeding. And the 5th question is which is the specific cause of the bleeding, and that question we're going to talk a lot about that in this class more deeply. So we are going to talk about now which is the specific cause of bleeding in the woman, a pregnant woman that is bleeding after 28 weeks of pregnancy. So as I said in the beginning, we had our first or seminar number 4. We talk about the bleeding during pregnancy before 28 weeks. And we remember the word amen to remember all the different causes. Yes? So it's abortion, molar pregnancy, ectopic, and normal pregnancy bleeding. All of that are the four main causes of bleeding before the 28 weeks. In this seminar, we're going to talk about bleeding after the 28 weeks. And for that, we will remember another religious mnemotechnic word, that is Mr. Pray. Mr. Pray, we're going to talk about him in the next slides. So, antepartum hemorrhage is the bleeding after the 28 weeks, by definition. Because after the 28 weeks here in Mbagathi hospital, in our MBU setting, in our hospital setting, we can have a chance to save this fetus. The viability of the fetus is after 28 weeks. This date can change with the years, also can change with the place. For example, in my country, in Chile, we talk about APH after 24 weeks. Because our setting, our MBU, is a little more sophisticated, so we can afford to save babies before 24 weeks. So now, the APH have 5 main causes. The first one and the most common is the mucous plug. But some people say that that is not an APH, it's also a PV, it's only a PV bleeding, but it's not blood coming from the uterus. We will talk about this later. But for you to know, it's a very common cause of bleeding during pregnancy. After that, placenta previa, it's also very common, 20% of all the APH. Abruptio placenta, 30%. So both of these are very common. We're going to talk about specifically one by one. And we have 2 ruptures that are rare. Air with air. Air from rare, air from rupture. Uterine rupture and vasa previa rupture are not so common, but it's important to have in our minds because are things that are very harmful for the patient, can kill the fetus, can kill the mother. So it's a thing that we need to know how to recognize it and how to start the initial treatment, and also to refer promptly, because the early diagnosis can save the life in this situation. And now, before I start talking one by one of all the APH, I want to talk about general important things about the APH, starting by the definition, that is a vaginal bleeding after 28 weeks of gestation that is unrelated to labor and delivery. The prevalence is 4 to 5% of all the pregnancies, so it is something very common. We will see a lot of these situations. This is very, very important for you. Please never forget the DE, or the digital examination of the cervix, should be avoided until the placenta previa has been excluded, have been ruled out. Why? Because if there is a placenta previa and you make a VE, you manipulate the cervix, and the placenta is very near the cervix, and it can start detaching and start bleeding a lot until it can kill the mother. So you need to avoid the vaginal examination in every patient that is coming because of an APH. And the last important general thing about APH is that the risk of premature delivery is very high in this situation. Maybe we don't know the diagnosis between all of this, but it's good if the mother is preterm, is below 37 weeks, to don't forget start early and prompt corticoid therapy. We cannot lose any hour. Every hour that we lose is time for the fetus to mature the lungs that we lose. So it's very important here to don't forget the corticoid therapy. So which is the specific cause of the bleeding? We have talked about the amen in the last seminar, and also here we make a little review. And now we're going to go by one with the Mr. Pray. But first, I want you to remember which are the causes of the Mr. Pray, and how does that fix in our mnemotechnic word. Is M from mucous plug, R from rupture of vasa previa, and the other R from ruptures of the uterus, then PR from previa, placenta previa, and the A from abruptio placenta. And the Y is not important here, it's only to make a sense in that word. So now that we know that Mr. Pray is someone that is going to help us, who is Mr. Pray? Here I want to make a little break for you. to tell you about Mr. Prey. He's a Latino reggaeton singer. Reggaeton is a type of music that we dance and sing in my country and also in all Latin America. In Latin America we speak Spanish, but the reggaeton singers, they love the English words and they want to become like English speaking persons. So for example, his name is Mr. Prey, that is an English name, but he speaks only Spanish. So he will help us to remember all the causes of APH because of this. I show you mucus plug, 2 ruptures of uterine rupture and vasa previa rupture, then placenta previa and abruptio placenta. All of these are in the name of Mr. Prey. So here I will show you 10 seconds of one of his songs, only to have a short relaxing time, because after this we will have to focus a lot, because we will see one by one the treatment, the diagnosis, the causes. So now I want you to only listen the song by 20 seconds. If you like the 20 seconds, you can search it on YouTube and you can listen completely.
Te regaló una flor, te regaló mi corazón, te regaló mi obsesión, te regaló ahora mi canción te regaló mi amor, te regaló todo mi calor, te regaló el ritmo del tambor, te regaló ahora mi canción, te regaló una flor, te regaló mi corazón, te regaló mi
So now I want to start this part of the seminar with a question for you. Which is the most common cause of PV bleeding after the 28 weeks? Please, I invite you to put in pause the video and think about it. Here we have all the different options: mucus plug, placenta previa, placenta abruptio, vasa previa, and uterine rupture. So I said to you a few clues before, in the slides before. Please try to find out which is the best answer. So the correct answer is mucus plug. Why? Because the key here is that I'm asking about PV bleeding. So it's bleeding coming from the vagina. But we don't know if that bleeding is from the vaginal walls, from the cervix, from the posterior fornix, from inside the uterus. So it's very common, the bleeding of the mucus plug. I'm going to show you why and how we can see that. So the mucus plug is this thing that is here. It's a plug that it's during all the pregnancy closing the cervix in order to protect the baby from infections, from ascending bacteria, and all of that. But when the labor is about to come, but it can occur like 3 weeks before. It doesn't have a very good relation with the start of labor, with the onset of labor, but it can occur. Normally it's like 1 week before or 4 days before labor, but it can occur 3 weeks before. The concept here is that when the labor is about to come, this blood is expelled. And for the mothers that doesn't know that is their primigravidas, or they have never seen one mucus plug, it's very common for them that they go to the hospital complaining, I am bleeding, and they are very scared, they are very worried, okay? But here the diagnosis key, is that there is a little quantity of blood. You will ask the mother, quantify the blood, please say to me, how much blood did you saw? Did you saw 1 cup of tea? Or a half cup of tea, or only kidogo? So with that you can quantify, and you can say, oh, this was only a mucus plug. The other important thing is that you have to ask her, do you have only blood, or blood with something, with mucus, with similar to the mucus that we have in our nose when we are in a flu, or something like that. So you can distinguish and make a differentiation between the fresh blood and the blood mixed with mucus, that is the characteristic of the mucus plug. Okay? And the treatment in this situation, if all the rest of the physical exam is normal, she's not in labor, and everything is normal, you don't have to worry and have to continue the pregnancy, saying to the patient that everything is okay. The key here, the principal key is that is kidogo blood. That is the important concept. If you think that it's more than a kidogo, we have to make further examinations. So here you have a photo of the mucus plug. It's something like this. It's not more quantity than that, and sometimes it's not with a fresh blood. It can be with old blood, ancient blood. Can be like something brown, a brown color. So we have seen mucus plug, and we're going to see now the first error, that is from uterine rupture. So the uterine rupture is the rupture of the 3 layers of the uterus: the endometrium, the myometrium, and the serosa, that is upper the myometrium. This is not common, but it's very, very important to know it because it's a very severe complication. The 0.3% of all the women that have a prior cesarean section can have this complication. If we induce the labor for this woman, the woman that have a prior cesarean section, we induce the labor with misoprostol or oxytocin, we can increase this risk. And also, every C-section that the mother have, it's an increasing risk. If a mother have 2 prior cesarean sections, it's a higher risk. If the mother have 3, more higher. And so it's very related to the prior cesarean sections. The clinical key here to diagnose this is that you will have fetal head rate abnormalities, because the placenta also can be inserted in the broken part of the uterus. Also, you can have PV bleeding, but this PV bleeding is not related with the quantity of blood loss. And the important thing here is sudden low abdominal pain. This is a very low abdominal pain, very intense, and that occurs very fast, in 1 second. And most of the time this occurs during labor, because in that moment the layers of the uterus are very stressed and are like with the myometrium is working, is doing force, so that can lead to an opening of the layers. But also it can occur not in labor. For example, if the mother have an accident, she fall down, or a car accident, and she have the prior cesarean section, also can happen. And the other clinical key here is the change in the contraction pattern. As the mother, as I said, she's in labor, she will have a normal pattern of contraction, for example, 2 in 10 minutes or 3 in 10 minutes, and of a certain time each one. But she can have a change in the contraction pattern. So start with a lot of contractions or stop the contractions will be a change. And also a loss of station. So the head will be engaged, for example, 2/5, 2/5, and after the rupture, the head will go up again and it will be floating, for example. The intra-abdominal hemorrhage can lead to a rapid maternal hemodynamic deterioration. Why? Because here we have the uterine arteries that are very important arteries in a gravid uterus. When the uterus have a fetus, these arteries turn very important, very big, and can supply like between the 10 and 20% of all the cardiac output. So if here we have a rupture, in 5 minutes the mother can lose all the volemia inside the peritoneum cavity, so she can bleed a lot from the inside, and you will not see any bleeding, or the vaginal bleeding can be modest. But the major intra-abdominal hemorrhage can be so big that she can be in a shock in only 5 minutes. So it's very important that you need to suspect this. And if you saw a mother in shock and she have a previous C-section years ago, maybe she can have a uterine rupture. It's very important to have the suspicion, because the treatment have to be very fast. So which are the risk factors for having a uterine rupture? I say to you that it's very related with the C-sections, so previous uterine scar, 1 or 2, or a classical cesarean section, that is a C-section that is not in this part, it's not in the segmental part of the uterus, it's in other part, maybe in the fundus or in the body of the uterus. Also, a previous uterine rupture, it's an important risk factor, and obstructed labor, also it's a risk factor for uterine rupture. Other important risk factors are oxytocin induction or misoprostol induction in a previous scar, and to apply the fundal pressure. The Christeller maneuver, it's also a risk factor for uterine rupture, and here in this hospital the people practice it a lot, and I know that sometimes you need to do it because you don't have a instrumental delivery, and you have a non-reassurement and the baby is almost out, and you need to do it because the theater is full. So I understand that there are some situations that you need to do it, but please avoid this practice when you have a previous uterine scar, and also avoid this practice, avoid to do it very strong, because when you do it very strong, you can lead to a uterine rupture. So it's important to be aware, and also if you're doing a Christeller maneuver and sometimes you feel like the presentation goes high and there is a change in the uterine dynamics and the mother is having a shock, you need to act very fast, because this can be a uterine rupture. So after the uterine rupture, we will talk about the vasa previa rupture. It's the second rupture, that is the second R. The vasa previa rupture have a very marked and important risk factor, that is the velamentous insertion of the cord. The clinical presentation is a PV bleeding that occurs immediately after the rupture of the membranes. And also you have associated a deep fetal bradycardia or asystolia. So if you don't find the fetal heart rate after performing a rupture of membranes, and when you do the rupture of membranes you saw a little of blood, that can be a vasa previa rupture. It's not a big bleeding because it's blood from the fetus, it's not blood from the mother. You broke the membranes and you broke the cord, the umbilical cord of the fetus that is inserted in the membranes. You broke this. So it comes out, all the blood, but it's blood that is coming from the fetus. It's this blood that is from the fetus that is coming out. So it's not a big blood, but the fetus can exsanguinate, lose all the volemia in minutes. And the risk factor here is, as I said to you, the velamentous cord insection, the placenta previa, and multiple gestation. I will show to you in a photo what is a velamentous cord insertion. So here you have a velamentous cord insertion. It's insertion of the cord in the membranes of the placenta. It's not inserted in the placenta directly, it's in the membranes. For example, look at me. In this hand, this is the placenta and this is the cord. If the cord is inserted just here, yeah, it's the normal, it's a placental cord insertion. But if the cord is inserted in the membranes and then go to the placenta by one edge, that is a velamentous cord insertion. It's not very common, but if you have that risk factor, you can have the vasa previa rupture. The problem is that we will never know if the patient has or doesn't have the velamentous insertion unless we have an ultrasound, a very high trained ultrasonographer or radiologist that can say to us. But in the most of the situation of here in Mbagathi, we wouldn't know. So we need to be have a high index of suspicion. And the emergency cesarean section is the treatment must be in 10 minutes. It's similar to have cord prolapse, but here, in addition to the cord prolapse and fetal suffering, we have a fetal exsanguination. The fetus is losing a lot of blood and very fast. So we need to ask fast, and we need to be able to recognize that. So the key message here is, if we do an artificial rupture of membrane and we saw blood coming out, first we need to check the fetal heart rate very fast. And then if the fetal heart rate, we cannot see it in 3 minutes, or if the fetal heart rate is very down, like 60 or 40, we need to go very fast for the emergency CS. We cannot send the mother to have a scan to make a confirmation. We cannot ask for a lab test to go to the theater. We need to make the operation very fast. Now we're going to talk about the PR of Mr. Prey, that is placenta previa. Placenta previa and abruptio placenta are the two common causes of APH, so it's important to know it very well. So the placenta previa, it's when the placenta is inserted in the lower uterine segment near the os. The 6% of all the pregnancies have a placenta previa by a scan before the week 20, but when the uterus is growing and going up, the placenta is also going with the uterus up. So after the week 20, the placenta go to the normal place. 90% of these cases solve, as in the explication that I said to you, that when the uterus grow, they solved, but there are persistent cases. And of that persistent cases, that is the 10% of that 6%, these cases, the 90% bleed. Maybe you get confused a little about the percentages. The important concept here is that at the beginning of the pregnancy, most of the placentas can be a low-lying insertion placenta, but when the uterus grows, that placenta goes up. But there are some situations that after the week 20, the uterus continue being low, and of that situations, the 90% can bleed. So what is the clinical presentation here? You have a painless vaginal bleeding that can be intermittent or continuous, but the key here is that it's painless. There's no pain. Apana uchungu. If the maternal hemodynamic is affected, I mean, if the mother is bleeding so much that she's now having a shock, the fetal heart rate can be affected. But before of that, if the maternal hemodynamic is not affected, the fetal heart rate will be not affected. Okay, that is a main difference between abruptio placenta that we will talk a little bit in a few slides. The 20% of the cases can have associated uterine contraction. So the definition of the clinical presentation, that is without pain, without contraction and everything, is not so true, because it can happen in the 20% of the case with uterine contractions, and so we need to rule out first the placenta previa before doing a VE. So the important message here don't do a VE never. So here we have a photo of the placenta inserted very down. So in this part, the placenta can bleed a little and can make the symptoms. So the placenta previa can have different positions and have different classification according to where the placenta is inserted, how far the os is. So here we have a low implantation placenta, when the placenta is not covering the os, but it's near the os, and it can bleed through the os. A partial placenta previa, when it is the placenta covering the os, but it's not in the middle of the placenta, it's only in the edge. And the total placenta previa, that is when it's completely covering the os. And here we have a normal placenta, that is when the placenta is in the fundus or in the anterior posterior wall, but not low lying. And which are the major risk factors of the placenta? To have previously a placenta previa, to have previous cesarean deliveries, because here the cesarean deliveries make a scar and make like this tissue to be more likely to the implantation from the placenta, and that also have more risk of placenta accreta, that we will talk about that in a few slides, and multiple gestation. Why? Because when you have a multiple gestation, you have more placentas, or you have one placenta that is bigger, so the chance of being covering the os, it's also a little high. Which associated pathologies we can have when we have a placenta previa? Well, these patients most of the time doesn't come alone. They can come with another things in addition. So they can have placenta accreta, that means that the placenta is the implantation of the placenta is more deep than the normal, and it insert in the myometrium. So it's at the moment of the delivery, it's difficult to pull it away. It's very difficult. So sometimes the mother bleed a lot, and you don't know what to do. Maybe the mother end in a cesarean section, on a hysterectomy. So it's a very important complication. Also, there is increta and percreta that are another forms of accretism that can go more farther than the accreta, like trespass de serosa, for example. All of these increase the risk in a placenta previa, because the lower uterine segment, that is the place where the placenta previa is inserted, is more thin. It's a more thin segment than the normal uterine fundus. The other thing that can happen is a malpresentation, that is, the fetus is not in cephalic, it's in bridge, for example, or in oblique, and that is because the placenta uses space down here in the pelvis, so the head couldn't fit very good, and increase the probability of the baby to take place with an incorrect position. Also the preterm labor, PPROM, and also increase the risk of vasa previa, because the placenta here is inserted in a normal way, so it also increases the risk of having a vasa previa. Placenta previa treatment. The first, well, you need to approach this patient, as I say to you, with the 5 questions. So you need to check first the ABC, if the patient is stable or not, and everything. But once you have the diagnosis a little more clear, the treatment is to admit the patient, perform an evaluation by a consultant, and to win time before the consultant comes, because we know in Mbagathi it's very difficult to have the help of the consultant. Maybe they are busy, or they can come but in an hour. So to win time, in that moment we ask for a lab test, blood group, because maybe she will need transfusion, also full hemogram to assess the quantity of blood, and an obstetric ultrasound if the patient is stable. We know that if the patient is not stable, we cannot send her to the ultrasound because it's very far away from the obstetric ward, and if the patient bleed more there and she become unstable, we can have problems. So it's important here to send the patient only if we think that the patient is very stable. Also, to achieve the long maturities, to start the corticoid therapy and continuous monitorization of the fetal head rate and the maternal well-being. And as we know, never do a VE unless we have ruled out the placenta previa. If the patient is not stable, the definitive treatment here is an emergency cesarean section, because we need to take away the placenta, that is the thing that is bleeding. And the baby, we will take care of him as it doesn't matter for us the gestational age here, because we have to save the mother that is bleeding a lot. So we have to make the cesarean section and be prepared for a neonatal resuscitation. If the patient is stable, the timing of delivery and the route of delivery depends on the consultant, because the placenta previa, the people think that always have to be delivered by cesarean section, because during the delivery, if the baby try to have an SBD, it completes a lot. But that is not true. There are some type of placenta previa that are not complete placenta previa, only partial, that can have a delivery by vaginal delivery. So this decision of which is the route of the delivery and when in an stable patient depends on the consultant. But for us, important to know that if the patient is not stable, if the blood pressure are very down, if she continue bleeding, if she is losing a lot of blood, and we cannot treat her with the transfusion and everything, and we cannot treat her good, we need to perform a cesarean section to save the mother. And the last cause of PV bleeding is the abruptio placenta. That is the A from the MRR PRAY. So here we have the placenta, and there are some situations in the pregnancy that leads to a detachment of the placenta from the uterine wall and start bleeding here, making a clot that separates the uterine bed from the placenta. So the exchange of blood here is not occurring. So the placenta, the half of the placenta from here to here, is not working. The only part of the placenta that gives nutrients to the baby is from here to here. So the baby can start suffering. So here's the most important difference with the placenta previa, that in the placenta previa the baby suffer only if the mother is with unstable hemodynamic, only if the mother is like in a shock. But here the baby can suffer a lot and the mother can be okay. That is the most important difference. So the definition is a partial or complete separation of the placenta prior to the delivery of the fetus, because we know that after the delivery it's normal for the placenta to separate from the uterus and go. But here we have this before the delivery of the fetus. The diagnosis, the patient can have PV bleeding, but not all the situations can have it. We will see that. Important, the patient will have abdominal pain, uterine tenderness, contractions, increased intensity and frequency of the contractions, and uterine rigidity and tenderness. And also non-reassurement fetal status, low fetal head rate, or meconium. There are some important parameters that can show non-reassurement fetal status, and it's important because that makes a difference between this and the placenta previa. So the abruptio placenta can occur like a concealed hemorrhage, that is a hemorrhage between the uterine wall and the placenta, but it's not going out. A partial separation but with apparent hemorrhage, that is in this situation, that is a detachment but the bleeding is going out, that is the most common. And a complete separation, that can have the complete separation of the placenta is not working at all, and there is no bleeding, and so this is a concealed hemorrhage again. In these situations the fetus of course can die, and the mother can have only pain and no bleeding, so we need to have a suspicion of this. In 10 to 20% there is no vaginal bleeding, so it's very important to know that, because sometimes the patient can have only pain and no bleeding, and she can have an abruptio. So placenta's abruptio refers to a partial or complete separation of the placenta prior to the delivery of the fetus. The classic symptoms and signs of acute placental abruption are vaginal bleeding, abdominal pain, contractions, uterine rigidity and tenderness, and possibly non-reassurement fetal status. In 10 to 20% of placental abruptions, patient can present with only preterm labor and no vaginal bleeding. Some abruptions are asymptomatic. The amount of bleeding does not correlate with the extent of maternal hemorrhage. So here we can have the situation that there is a lot of bleed of the mother here, and she's getting shocked, maybe, but she's not PV bleeding. So it's important to know that, because we need to look, we need to search for this type of situations. If there is no fetal head rate, we need to maybe perform an ultrasound to check if there is a clot between the placenta and the uterine wall. So which are the risk factors for the abruption of the placenta? Here we have abdominal trauma and accidents, cocaine use. That is not very common in our setup, but it's important to know. Maybe other drugs abuse, polyhydramnios, because the important is tension of the uterus, and then the rupture of membranes can lead to a very fast decompression of the uterus, and that can lead to a placental abruption. Also, when you have a twin pregnancy and the delivery of the first pregnancy, of the first baby, can lead to a placental abruption from the other baby that is inside. There are medical risk factors from like chronic hypertension, preeclampsia, it's a very important risk factor. Eclampsia, it's also a risk factor. PPROM, chorionitis, previous ischemic placental disease, previous abruption in other pregnancies, also a risk factor. And the maternal age, advanced age, the parity, smoking, male and infant. But the ones that I have marked are the most important and most related risk factors. So which is the treatment for the abruption placenta? As I said to you in the placenta previa, it's very similar. You need to assess this mother in the 5 first questions that start if the patient is stable. So you need to check the ABC and if the patient is neurologically stable or not. All the things before starting the definitive treatment that are about management of shock. But if the patient, assuming that the patient is good, after that questions, you need to, knowing the diagnosis of placenta abruption, you need to admit, and if the patient is stable, perform a scan and lab exams. Always the evaluation by a consultant, because he takes the important decisions. And if the gestational age is above 28 but below 37, give corticoids, because this mother maybe will have to deliver very soon. So it's important to give corticoids while you wait for the consultant, and while you wait for the consultant also it's important to have the lab exams. The definitive treatment depends on the type and the grade of abruption of the placenta and the gestational age, but it can be immediate pregnancy termination, like to perform a CS pretty fast, or conservative management, or conservative management only by 2 days, only to perform the long maturity and then the pregnancy termination. All of these decisions are taken by the consultant depending on the state of the fetus, if there's non-reassurement fetal status or not, depending on the gestational age, depending on the quantity of bleeding of the mother and the mother well-being. So we talk a little bit about all the different causes of early pregnancy bleeding in the last seminar, and now from antepartum hemorrhage in this seminar. And we talk a little bit about the treatment, like the initial treatment, but all the times the treatment finish like the consultant have to decide, or we have to talk with the consultant, and that is true. We need to work as a team. We need to ask to the person that have more experience in that. So it's important, but also it's important to not call the consultant all the time, because it's a resource that we have and it's a limited resource. So we need to know how to triage our patients, how to select our patient, and how to choose which patient needs and which patient doesn't need the decision of a consultant. So here we have some situations that I classify in which the patient doesn't need to be seen by a consultant, and some situations that are emergencies that also doesn't need to be seen by a consultant, because the decision of finishing the pregnancy must be taken by us or by the EMO on call. So first, the mucus plug, the normal pregnancy bleeding, and the complete abortion with a stable hemodynamic, no need to call a consultant. You can diagnose by your own if you have the tools, if you have the ultrasound and all of that, or the patient comes with the result of the ultrasound, you can diagnose that. For example, the mucus plug, it's very easy to diagnose, only with the clinical history. If the mother bleeds only a kidogo and the physical exam, the complete physical exam is okay, the baby is okay, and all of that, there's no need to call a consultant. There are some situations that are the intermediate, that are not the very big emergencies, but it's important to call the consultant. That is ectopic pregnancy, abortion, all the other types of abortion, placenta previa, placenta abruptio, but without fetal bradycardia, uterine rupture, but all of them with a stable hemodynamic must be managed by the consultant, or at least have the opinion of the consultant, and start the initial study and inform the medical officer, because the patient will need a cesarean section now, but the decision of that can be taken with more time. And if we have this type of emergencies, unstable hemodynamic, that means the mother blood pressures are very low, or the mother is in a deep shock, by any cause of all of this. But if they have an unstable hemodynamic, it's an emergency. Also, if we have a vasa previa rupture or an abruptio with a fetal bradycardia, that means we need to act fast. If we call people, if we call the consultant, or if we wait for the labs, maybe if we wait for the laboratory test, maybe we wouldn't be able to treat this patient. So in these situations are emergencies. The life are in an immediate risk, so we usually can need immediate surgery. Of course, you cannot be able to do the surgery alone. You need to talk with the EMO on call, but the concept here is that you have to do all the things very fast. So it's fast initial emergency management. Review the shock seminar if you have doubts about that, and fast and ask for help. The consultant, the EMO, or the MOI, the one that is in the hospital. That is the concept. You cannot wait for someone to take a car and come to the hospital to take a matatu. No. You have to ask for someone that is in the hospital, because this must be solved very fast. So here we have the 3 different levels of an emergency that we have to be able to select between them, to know if we need to call someone else, to know the velocity in which we have to call for help. So now that we have finished our classes, I want to share with you the little golden potatoes that are the take-home messages. First, sorry for my English, and if you confuse a little, you can ask for me anything by WhatsApp or by email or by whatever. So the points are: vaginal bleeding during pregnancy is a very common complaint. Use the 5 questions in the correct order to approach the diagnosis. First, always start with the patient if it's stable or not. After that, to check the site of bleeding. And after that, to check if the patient is pregnant really or not, and if the pregnancy is viable or not, so if the patient have or not fetal head rate. Then the gestational age, and then the specific cause. For the specific cause chapter, we use this word, so please don't deny your religious mind, and use always the word Amen, or Amina in Kiswahili, and Mr. Pray, with 2 R's. So if you remember those 2 words, you can remember all the time all the causes of PV bleeding. Don't do a VE in antepartum hemorrhage, please don't do a VE. Also in early pregnancy bleeding, only you can perform the VE if the os is open when you do the speculoscopy. If you have doubts of that, you can check the seminar number 4. To earn time, it is good to start the complementary study, laboratory and obstetric scan if the patient is stable, and do not forget the corticoids if there is a preterm pregnancy. And the concept that I always say to you, always ask for help, because we work as a team and we will always need the help of all the people in the hospital. Thank you very much. See you in the next presentations.